Hi folks, welcome to my YouTube channel. So in this video, we will discuss about the leiomyoma and its different subtypes. So what is the conventional or the usual leiomyoma? We will discuss about its definition, prognosis, and how we can diagnose it under the microscope and its different subtypes. So there are variety of subtypes which includes highly cellular leiomyoma, leiomyoma with basal nuclei, fumerate hereditary deficient leiomyoma, apoplectic leiomyoma, mitotically active, hydropic, lipoleiomyoma, epithelioid, myxoid, dissecting, diffuse leiomyomatosis. So out of those subtypes, we will only go over the first four because these are the first four who carries a different prognosis and they have a different percentage of incidence or the risk associated with them in terms of their reoccurrence. So starting from the definition of the conventional leiomyoma, this is a benign mesenchymal tumor which derives from the smooth muscles and it is one of the most common uterine tumor. In terms of incidence, it's the most common tumor of female genital tract and it commonly occurs during the middle age to the elderly age, but sometimes it can occur in the earlier age, especially around the mean age of 28 years. So whenever it occurs in a early age, we have to keep in mind that it could be the subtype of the leiomyoma, especially the fumerate hereditary germline mutation associated leiomyoma. We will discuss further about this entity as we goes further down. In terms of ethnicity, it has the higher incidence in black women and commonly it appears in them at the earlier age compared to the other ethnicities. While in terms of a site, it commonly appears in the fundus region of the uterus and in 2% it can occur in the cervix. Even though the leiomyoma is the benign, is the most common, but it has the clonal origin. So in 70% of the cases of the conventional leiomyoma, it harbors a point mutation at MAT12 gene or in 40% of the cases, it has the mutation in HMGA2, HMGA1 rearrangements, or in some cases, it might have COL4A5 or COL4A6 mutation as well. And in the some rare cases, but highly important, is the fumerate hereditary deficient leiomyomas. While in terms of presentation, it can be totally asymptomatic or sometimes it can present with the menorrhagia, hypermenorrhea, abdominal pain, swelling. Sometimes female undergoes the history of repeated abortions or infertility, or sometimes when the leiomyomas have the pedenticulated leiomyomas, they can undergo torsion and they can present with the acute abdomen or they can cause the vaginal bleeding as well. In terms of a gross description, they are commonly located in uterus. So in the uterus, they can be intramural, submucosal, and subserosal. They are commonly multiple and they are well circumscribed, but they are not capsulated. On the cut surfaces, they appear white or tan white, rolled, firm, bulging, and sometimes they can undergo degeneration if they are if there is no sufficient amount of a blood supply, so they can undergo hemorrhage or infarction, or they can present with the calcification as well. And if there is a center or the foci of hemorrhage in the center, then we call it as apoplectic change, which is commonly associated with the progesterone therapy, and we will discuss about the zonation phenomena in the apoplectic leiomyoma as well. So this is the uterine fibroids. So the one which is located just beneath the endometrium is known as the submucosal fibroid. The fibroid which is located inside the muscle is known as the intramural fibroid, and the fibroid which is just beneath the serosa is called as the subserosal fibroid. And the fibroids which has the peduncle, so they can undergo the torsion and then they can cause the acute abdominal symptoms. So this is the gross picture of the leiomyoma or the fibroid, which is well circumscribed, white bulging, firm, but however they are not capsulated. So microscopically, in discussing only the conventional or the usual leiomyoma, so the first thing we have to notice that it has the spindle type of the morphology. So the spindle type of the morphology can also be seen in neuroma, neurofibroma, or any other fibrous related tumors. So first, the morphology for the leiomyoma is it will be a spindle in nature, and then those spindle cells forms a big fascicles, and they are commonly have well-defined borders. They are normocellular, and then those big fascicles will intersect with each other, and they when they interact with each other, they would not have any distinct borders, and they have a characteristic nuclei which is known as the cigar-shaped nuclei. So this nuclei is with the tapered ends, and they commonly have a small nucleoli. So whenever we are looking leiomyoma under the microscope, we have to pay attention on three features: atypia, number of mitosis, and the coagulative necrosis. If we have a sufficient atypia, mitosis, or the coagulative necrosis, then we have to bump up, or it will be up stage from the conventional leiomyoma to the smooth muscle tumor of the uncertain malignant potential, which is also abbreviated as the STEM, which we will discuss in our next video. Or if more than one feature such as atypia and greater number of mitosis are present, then we might be dealing with the leiomyosarcoma. So about their features and their criteria, we will discuss in our next video, but we have to pay attention on atypia, number of mitosis, and the coagulative necrosis. So this is the microscopic picture of a conventional leiomyoma. So the first thing we have to notice is the spindle cell morphology, and then they form a big fascicles which intersect. So say for example, this is a one fascicle here, there's another fascicle here, so they are intersecting with each other, but and there is no clear boundary when they are intersecting with each other, so they have the indistinct border in between them. This is the another picture which highlights there is a big bulk of the fascicles. And then discussing about the cigar-shaped nuclei, so they have these tapered type of the ends, and there is hardly any prominent nucleoli in them. But if we see a very prominent nucleoli all over, then we have to pay careful attention whether there's a atypia or not, no atypia. And now discussing about the subtype of the leiomyoma. So the first is the highly cellular leiomyoma. So as the name implies that it will be a leiomyoma, but here the number of cells will be higher. So whenever we are dealing with the highly cellular leiomyoma, previously it was known as the cellular leiomyoma, but currently in the WHO it has been named as highly cellular leiomyoma. So whenever we are dealing with higher number of the cells, always we have to make a differentiation with the endometrial, especially the low-grade endometrial stromal tumors. And first, focusing on the highly cellular leiomyoma, by definition, is the high amount of a cellular density which possesses no cytological atypia, and if there is a mitosis, the mitosis should be less than 10 mitosis per 10 high power fields. They may have irregular pseudo-infiltrative borders, but they commonly shows the margin, which means like we can have a conventional leiomyoma at the one portion, and then we have a highly cellular leiomyoma in the next to it. So we can make a clear distinction above the highly cellular leiomyoma, and they also contains a thick walled blood vessels throughout, and the cleft-like spaces which represents the compressed vessels or the retraction uh, can be a retraction artifact as well. So this is the one of the morphological feature which can be helpful to distinguish it from the low-grade endometrial stromal tumor. And if we are still not sure morphologically, we can do CD10 stain. So the CD10 is sensitive, and the specific markers for the low-grade endometrial stromal tumors, while it will be completely negative in the leiomyomas. So this is the microscopic picture of a highly cellular leiomyomas. So here on this portion, we can completely see there is a high amount of a cell. But if we go on the left side, we see a normal spindle cell morphology and a normal number of cells. But if we go, then we can completely merge, or there will be a increased number of cells. Same goes here as well. In this picture on the right side, we have a normal amount of cells of a leiomyoma, and then suddenly they have a higher number of a blend looking spindle cell cigar shaped nuclei are the cells, but no atypia, no higher number of mitosis. So discussing about the next entity, which is the leiomyoma with basal nuclei. So as the name implies, we will have a leiomyoma, but this time the nuclei will have a basal type of a shape. So these nuclei can have a patchy distribution, or they can be diffuse as well. And commonly they are binucleated, or sometimes they can be multinucleated as well. Why they have a basal shape? Because there is an inactivation of our DNA into them, and sometimes they possess abundant eosinophilic cytoplasm, and when they have a high amount of a pinkish cytoplasm, they can have a morphology of a rhabdoid as well. And another feature is that sometimes there might be abundant karyoretic nuclei, so be careful where to differentiate it from the mitosis. So the abundant karyoretic nuclei can give a appearance such as the mitosis, but pay a careful attention whether it's a pure mitosis or whether it's a karyoretic nuclei. Sometimes they can undergo a vascular changes, which includes fibrinoid necrosis, vascular occlusion, and the perivascular infiltrate as well. So this is the picture, microscopic picture of a leiomyoma with a basal nuclei. So here we can see there's a multinucleation, and here is a multinucleation as well. In some areas we have a binucleation, and here is the example of a karyoretic nuclei. So pay attention whether it's a pure mitosis versus the karyoretic nuclei. However, we still in this entity we have some vascular changes, which includes, so this is one of the vessel which is surrounded by the inflammatory other lymphocytic type of the cells, and this is another picture which highlights there is a fibrinoid necrosis or some vascular changes are present. However, as we see these vascular changes, they are surrounded by these bizarre appearing nuclei. So whenever we have the bizarre type of a nuclei, we have to make distinction with the another entity or another subtype of a leiomyoma, which is a fumerate hydratase deficient leiomyoma. So how we can make a distinction is the on the basis of the fumerate hydratase immunohistochemistry or the histochemical marker, which will be lost in the fumerate hydratase deficient leiomyoma, but it will be positive in this. And there are some other features such as staghorn vessels and other few minor features which are present in fumerate hydratase deficient leiomyoma, which we will discuss further, but those features will be not present in the leiomyoma with basal nuclei. So the another entity is the fumerate hydratase deficient leiomyoma. As we discussed few features in the previous slides, so they have microscopic features So the important ones are the staghorn or the hemangioperistoma-like vessels, which are like a staghorn type of the vessels, large vessels which represents the staghorns, and these type of the vessels are not only present in the leiomyomas, but they can present in the solitary fibrous tumor as well, and other entities as well, such as glomus tumor. So and other features along with those, the important includes the rhabdoid are the eosinophilic cytoplasm inclusions, which are not present in the leiomyoma with the basal nuclei, and they may have a multinucleated cells with the basal nuclei. Other features which includes alveolar edema, which can be seen in the other entities as well. They have a chain-like growth of a tumor cells, and they have a spindle or the epithelioid cells with the oven nuclei and the prominent eosinophilic nuclei, which are surrounded by the perinuclear halos. So the whenever we are dealing with the fumarate hydratase deficient leiomyoma, always pay attention whether the patient is suffering from the hereditary leiomyomatosis or and the renal cell cancer, which is abbreviated as a HLRCC. So it's a hereditary condition which commonly comes as an autosomal dominant, which possess the unique features of developing. Patient will develop multiple leiomyomas, which includes in the skin and in the uterus, but down the line, patient might develop an aggressive form of a kidney cancer. So important point in this syndrome is that the leiomyomas which are present in the skin and in the uterus, they commonly are indolent and they are commonly benign. But down the line, the patient develop the cancer of a kidney or the renal cancer, those will be very aggressive. So there is a strong follow-up, and patient should be put on a strong surveillance in order to detect those kidney related cancers in the early time, because they are very aggressive and they carry very poor prognosis as well. So in this syndrome, the gene which is known as the fumarate hydratase gene is believed to cause all known cases of the HLRCC, and the fumarate hydratase is the normal enzyme in the Krebs cycles. So whenever we have a fumarate hydratase deficient leiomyoma, they commonly reoccur, and the strong genetic counseling is recommended as well. So this is the example of a fumarate hydratase deficient leiomyoma, in which we can clearly appreciate there's a spindle cell morphology, and then we have these multinucleated basal-looking nuclei, and when we see if we in other areas, we see these eosinophilic type of the inclusions, which are along with the basal nuclei, along with the eosinophilic inclusions, and the other features such as these staghorn vessels, which we already discussed. Is in terms of leiomyomas, they are commonly present in the fumarate hydratase deficient leiomyomas, but in terms of other tumors, they are commonly seen in solitary fibrous tumors and other type of the tumors as well. So these staghorn type of the vessels, along with these bizarre nuclei and the eosinophilic inclusions, always think about the fumarate hydratase deficient leiomyomas. And this is the example of the alveolar type of the edema, which can be present in the other subtypes as well. So why it is known as the alveolar type edema? Because it has that morphology into it. And whenever we are dealing with these bizarre nuclei, always do a screening marker, which is the fumarate hydratase deficient or the fumarate hydratase immunohistological marker, which will be absent or lost in those bizarre type of the nuclei. So pay attention how to interpret this stain as well, because the loss of staining is it's positive for this type of the leiomyoma, while this other positivity is non-specific and it is occurring in the blood vessels. So the last category is the apoplectic leiomyoma. So as the name implies, it will have some necrotic type of the pattern and are the hemorrhage, and it is commonly under the influence of a progesterone. So by definition, it will have a well-defined area of the hemorrhage, which is known as the zonation phenomena as well, which is surrounded by the cellular rim of a smooth muscles with a plump nuclei, which can have a prominent nuclei as well, and sometimes they have an increased number of mitosis. So up to 9 per 10 hour field is still the apoplectic leiomyoma, but if the number goes above the 10 or reaching up to 15, then we can bump up this leiomyoma into the stump, which is the smooth muscle tumor of uncertain malignant potential. So we will discuss about that entity in our next video. So discussing about the microscopic features of this entity is that surrounded, like the center has the hemorrhagic area, and then surrounded by the smooth muscle cells are the plump smooth muscles. So this phenomena is known as a zonation phenomena, in which we have a center of a necrosis or the hemorrhage, and then which is surrounded by the smooth muscles. And then this is another picture which highlights the zonation phenomena. And in when even the morphology rules here. So in whenever we have to make a distinction to the other tumors, we can through desmin h calcimon or smooth muscle actin, but they are hardly ever used because the morphology rules here. And then in terms of a prognosis, so all of them carry a different prognosis. If there's a not complete resection of these tumor, then reoccurrence can occur, especially when the myomectomy is performed and some of the portion is remained in the patient, then the reoccurrence can occur. And sometimes the distant reoccurrence can occur, especially in the lung. It's a bit controversial whether when we have a distant reoccurrence of these in the lung, then it's a controversial being a benign. How can it is metastasizing? So it's a bit controversial what term needs to be used, and sometimes they can progress into the leiomyosarcoma as well, but the incidence is less than 3%. And another prognostic point was the fumerate hydratase deficient leiomyoma, because in these entities, genetic counseling is needed, and follow-up and surveillance for the kidney cancers is also recommended as well. So this is the end of my presentation.